Dear Chairman, dear colleagues, good morning. Colloid cysts, well, I have no disclosures. Colloid cysts have been treated primarily by microsurgical excision and are still treated by microsurgical excision, which is the gold standard, or at least that it has been this gold standard for many years. However, if we look at the published series in the literature, we can see that morbidity can be a problem. We can have vascular complications and fornix damage in this kind of approaches. And for this reason, endoscopy has been started several years ago to treat these patients. We need to make a comparison between the two techniques, and actually in the literature we can find three reviews, systematic reviews of the literature and meta-analysis. And as you can see from these papers, for sure microsurgery can guarantee higher gross total removal compared to endoscopy. And endoscopy has higher rates of recurrence and reoperation. However, the morbidity is much higher with microsurgery. And all these meta-analyses are matching with these results. Even the most recent one, which is this one, published in 2022. So lower rate of complications in the endoscopic group, lower shunt dependency, but higher recurrence rate and less gross total resection. However, we have to say that in the last years, endoscopic techniques changed, and these meta-analyses include all patients treated by endoscopy, even those patients, especially those patients initially treated with endoscopy. And initially, endoscopy aimed only to making a hole on the surface of the cyst, sucking off all the content of the cyst, and that was it. But if we do endoscopy like this, what we can expect, of course, is a recurrence of the colloid cyst. Later on, another technique has been introduced, which is making a fenestration on the cystic wall, and then making another fenestration, at least two fenestrations. So in this way, the CSF flow can keep this stoma open, and the recurrence rate drop dramatically. But nowadays, it is possible not only to fenestrate the cyst and remove its contents, but also to completely remove or almost completely remove the wall of the cyst itself. And this is a huge advancement because we can really decrease dramatically the rate of recurrences. Another advantage of the endoscopic technique is that we can avoid depletion of CSF during surgery, and this keeps the walls of the third ventricle open. This is something that we described for the fourth ventricle, but obviously it is applied also for the third ventricle. This is our series of patients, and you can see that we had no major complications in our series. We had just one patient with a millimetric residue of the capsule, but so far no regrowths, no recurrences in patients treated by endoscopy. Just a couple of cases to show the technique. This female, 28-year-old female, presented with worsening headache and vomiting in the last 7 days. She presented in emergency situation, as you can see, GCS 7. An EVD was placed immediately, and diagnostic MRI showed the colloid cyst of the third ventricle. She was operated with an endoscope. This is the video, the intraoperative video. I will try to move on a bit faster. So initially, we coagulate the choroid plexus and also the capsule of the tumor, and sometimes some small bleedings can happen, but just irrigation is enough to control them in most of the cases. And then we start grabbing the wall of the cyst. We don't pull out the forceps, but firstly we twist the forceps like we do when we eat spaghetti. So this is safer before pulling out the forceps after grabbing the tumor. And moving on faster, we can remove the content of the cyst and remove also the opposite side of the cystic wall, as you can see with the same technique. And I like using both rigid and flexible endoscopes in these cases, because with the flexible endoscope I can actually remove eventually some blood clots into the third ventricle or some remnants of the colloid, and I can look around the corner to make sure I didn't leave some pieces of the cyst behind. In this case, male, 50-year-old, with 3-year history of gait instability and cognitive impairment, again, colloid cyst of the third ventricle. We used both rigid and flexible endoscope. I start usually with a flexible endoscope. I feel more comfortable, less chances to damage the structures, especially the fornix. But in this case, the cyst was quite stiff. So I switched to the rigid endoscope, and I removed this hard part of the colloid cyst. As you can see, you can also use scissors in these cases. I grab the colloid, and then I use the flexible scope to, again, look around the corner and make sure that nothing is left on the roof of the third ventricle. So I think that endoscopy allows for a complete or near complete colloid cyst removal. In our patients, we could obtain a fast recovery and a fast discharge from the hospital. It is possible to obtain a lower complication rate because the technique is really minimally invasive. And in particular, the flexible scope sometimes can be enough to complete the resection itself, but it's mainly an adjunct to explore the posterior part of the third ventricle and the adytum of the cerebral aqueduct, which sometimes can be obstructed by blood clots and remnants of the colloid after we remove the colloid cyst. Only simple maneuvers are necessary with this technique: fenestration of the cyst, aspiration of its content, and the spaghetti technique to twist the forceps and remove completely, if possible, the cystic wall. Sometimes bleeding can occur. Irrigation is enough in most of the cases to control the bleeding. Sometimes I had to use coagulation, very rarely, to be honest. And in one case, just in one case, I had to use the so-called dry field technique. So